Thank you, Senior, for the introduction. As ma'am said, today we are going to learn about breathlessness and cough. We all know that breathlessness is one of the most difficult and challenging symptoms which we have seen very often in our settings. Uh, let's see how we will manage in palliative care settings those symptoms. We all know that the one of the most important aim of palliative care is reducing symptoms so that we can improve the quality of life of the patient and their family that way. So today, Dr. Sreedevi with us, who is a palliative care physician, having more than 10 years of experience in palliative care. She did her certificate course in palliative medicine from Pallium India and fellowship in palliative medicine from Institute of Palliative Medicine, Calicut. And also she did her MSc palliative care from Cardiff University, UK. We are very lucky to have you here, ma'am. So welcome and over to you, ma'am.
Thank you, Sister Shiva and Senior, and thank you all the nurses for joining today's session. I'll just tell me if there is any glitch so that I can switch off the video. So I'll start sharing the screen. So as Sister Shiva mentioned during the introduction, this is one of the symptoms that we see very, very commonly in palliative care patients. So it is when you hear respiratory symptoms, it is not just related to respiratory issues or breathlessness related to lung cancer, but in many other illness, we see a lot of respiratory issues for patients coming to palliative care. Just a moment. Sorry. So, so we know why it is very important, because even when we do the morning vitals or the vitals when you take charge of a particular patient, you do all this, right? BP, pulse, temperature, and which includes respiration. So we know how important it is to measure respiration, to understand more about respiration, and to treat issues dealing with breathing. And we all know that after COVID, maybe we are all aware of how important the breathing is for each person, because people were so breathless, people were admitted in hospitals, people were dying out of breathlessness. So we, at least after the COVID, we understand that managing symptoms of respiration, any problem with respiration is very, very important. And when it comes to palliative care, this is one of the most common symptom seen in many patients, not just in lung cancer, but in many other illnesses also. So this is a one scenario where Miss S, she's a 50-year-old female, and she was started having shortness of breath 2 weeks back, and she consulted a nearby hospital, and she was not a known asthmatic or hypertensive. And as the breathlessness, so initially they gave oxygen, I mean antibiotics and everything, but the breathlessness continued. So then they took X-ray chest, and in the X-ray chest, it was shown there was multiple radio-opaque lesions. Almost whole of the lung was filled with radio-opaque lesions. And it was not, they found out that these are all secondaries from an unknown primary. And she was so breathless that she was admitted in the respiratory ICU, and she was put on continuous oxygen. Yet they were yet to find where the primary cancer is, but she was very breathless. So she was referred, she has a husband who is a coolie worker and a daughter, a very grown-up daughter, like 16, 17 years old daughter. And she was referred to palliative care, and they initially told that you can go home because there is a lot of I mean, problems in your lungs. So the test will take time. So either you can go home or go to a palliative care center. So they came to us in this situation. So when we went to the respiratory ICU, she was totally breathless. The moment we think about or talk about removing the oxygen, she starts becoming more and more breathless. So this was one situation where the breathlessness, the acute breathlessness was referred to palliative care. And this is another scenario where Mr. H. So this guy was a young guy who was working in a Gulf. He was recently married and have a very small child, 2.5 to 3 years of age. And while he was working in Gulf, he started having shortness of breath. So after, over a few weeks period, which aggravated really, really bad, and he could not afford any treatment from abroad. So he came back home to Kerala. So he was from Kerala Tamil Nadu border, and he was referred to a medical college in Kerala, and he was put on a continuous oxygen. He was in the respiratory ICU, and the condition was diagnosed as asbestosis. And even with continuous oxygen, which was put on him with maximum flow, he was very, very breathless. So this was another person who was referred to palliative care. So I just wanted to convey that it is not just lung cancer. It is not just primary lung cancer where people die of breathlessness, but this is a pure non-cancer case where patient was severely breathless even on oxygen. So we think oxygen can reduce all the problem, but no. Even with oxygen, both of these patients were on severe breathlessness. And the respiratory medicine people did not, they were clueless how to manage, because both of them, what they can do, they can give oxygen. They can give antibiotics, bronchodilators, everything was given, but both of them were very, very breathless. So coming back to, so we will come back to these scenarios later on. Coming back to the breath. So the breathing or respiration is not just taking in air, oxygen exchange, carbon dioxide coming out. It is not just a physiological process. But we know that through breathing, people convey a lot. When someone is in anxiety, their breathing pattern changes, right? And if someone is desperate, like depressed, when you ask something, then we give a sigh. So we communicate a lot through a normal breath. You can, when you start talking to patients, if you notice that according to the topic, according to their mental status, the breathing pattern also changes. So it is not just taking in oxygen and breathing of carbon dioxide, but it is very closely linked to the psychological status. It conveys the spiritual, and it gives a lot of physiological hints that we can pick up on, even when we communicate a bad news. So you have all heard about the communicating bad news part. So when we communicate the bad news, we can see the patient's breathing pattern changes when we communicate very serious thing. Or sometimes when you ask, what do you think about it now? Then they just keep silent and their breathing pattern changes. So these are the things that we need to know about the normal respiration. And normally, when we breathe, we don't know. It is totally involuntary. But when there is an illness, even breathing becomes too laborious for patients. And this is the definition given by American Thoracic Society. We don't need to learn the whole definition, but we have to understand it is a pure subjective experience of breathing discomfort. And it has a lot of qualitative variance that varies from person to person. As we said, pain is very subjective. Pain is what patient says it hurts. Likewise, breathing or dyspnea, breathlessness, is also a very subjective experience of breathing discomfort. What looks like breathlessness may not be a problem for the patient. They may look breathless, but they might be okay. So it is purely subjective. So how common breathlessness is? Uh, um, so as I said in the beginning, it is not just in lung cancer. Sorry, I can't see my own presentations fully. So it is very commonly seen in patients with lung cancer, very common. 75 to 87% of patients with lung cancer will have breathlessness. But in a study, it has shown that there are 11 symptoms in patients with advanced cancer, any advanced illness like HIV, heart disease, renal disease, COPD. So there were 11 symptoms, which is very commonly seen in many of the end stage issues, where there were more than 50% of patients who had breathlessness. So it is not just in lung cancer that we see, but we see breathlessness in any other advanced cancer, HIV, heart disease, COPD, and many other renal issues. And when they are about to reach the dying time or end of life situation, breathlessness will increase in the last 3 months to the time of death. So it is very common, even when a normal patient is dying without any illness, without any comorbidities. When an aged person is dying, there will be some respiratory symptoms that they show very commonly. And when you ask patients, there are two patterns described by patients. One is a continuous dyspnea. They say all the time they are in the background, they are breathless. That is not the commonest form. The commonest form is breakthrough dyspnea. That is only when they exert a little bit, when they try to get up and walk, when they climb stairs, or for some patients, even while eating. Any small exertion can cause, we call it exertional breathlessness, or you can say breakthrough dyspnea. That is the most commonest form. And there will be a background continuous dyspnea. These are the two patterns described by the patient. And when it comes to cancer, it is mostly seen in the last few days of life. But in non-cancer, the breathlessness will be longer. So there will be breathlessness, lesser quantity, lesser intensity of breathlessness for a long period of time in non-cancer patients. But in cancer, the breathlessness increases mostly in the last few days of life. What are the qualities of dyspnea? So we have heard about the pain assessment, where we ask the patient, when did it start? What is the pain score? What is the quality of pain? Pricking, piercing, stabbing kind of pain. Same way, we can assess the quality of dyspnea. So these are the common, three common variants that people tell about. So when you ask this question, it is very easy for us to understand what type of breathlessness they have. So the first one is air hunger or unsatisfied inspiration. The second one is work or effort. And the third one is chest tightness. So these are the three important categories of qualities of dyspnea. And each quality will have different pathways also. You don't need to learn about the pathways, but to understand that each of these have different pathways of occurrence. So first we'll talk about air hunger. Air hunger is usually when the patient is telling this is a conscious perception of the urge to breathe. We usually say, I cannot get enough air, or my breaths don't satisfy me, or I'm starving for air. How much ever I put effort, I'm not satisfied with whatever I'm breathing. I'm feeling that I'm not getting enough air. So usually it is associated. So it's a very simple example. When you exercise, you feel how much ever breath you take, you are not getting enough air, right? So it's the same way. It is usually seen along with exercise. And you don't need to get into the pathway, but if someone wants to read it from the slide, that is fine. The second thing is work or effort. This is an uncomfortable sense of respiratory work. That is, the patient feels so tired. It is a big effort to breathe, or I feel my breathing requires more work. I have to put in a lot of work just to take a breath. And the third one is tightness. Many of you have had experience of chest condition, right? Where you have a lower respiratory tract infection, where you have a bronchoconstriction, you feel the chest is very tight. At least during COVID, many of us have experienced the chest tightness. So this chest tightness indicates bronchoconstriction. And very importantly, The pathway of dyspnea overlaps with pain pathway. What does that mean? If someone has pain, there is a chance that they will have breathlessness also. You might have seen in patients with severe pain, their breathing pattern also changes. Or patients with severe dyspnea, they might show some symptoms of pain. So dyspnea and pain pathway always overlaps at one point. So these are the three things that we discussed: air hunger or unsatisfied inspiration, a lot of work or effort, and the third is chest tightness. So this is a simple pathophysiology. You don't need to learn about the nerve endings or the pathways. This is one important thing that I want you to take away from today's session. That is, whenever there is dyspnea, everyone thinks about death, right? You might have heard during COVID, people sharing their experience. Even before COVID, when we come across patients who are dying, patients who have lung cancer, COPD, or any other illness, when you ask them when they are breathless, what is that you are scared of? They see when they are unable to take air inside, they think that they're going to die. Am I going to die without getting proper breath? Like everyone is scared when they don't get enough air to breathe. So when they are scared or there is a fear of dying, it increases the anxiety. So when there is increased anxiety, there is more and more breathlessness. You might have experienced when you get into an exam hall, when you are just at the entrance of the exam hall, you will be very anxious. Then the breath rate increases. There will be a change in the breathing pattern because anxiety causes breathlessness. The same way, when someone is scared of dying, scared of their illness, they will be anxious. Any anxiety can cause dyspnea. So this is something, a new concept called chronic breathlessness syndrome. It is called breathing, thinking, and functioning model, where this is a kind of same thing that I just mentioned. The breathlessness is associated with the thinking, functioning, and breathing. When there is not enough or insufficient breathing or increased work of breathing, there is breathlessness. And they use a lot of accessory muscles and there will be increased respiratory rate. Second thing is thinking, thoughts about dying, misconceptions, and past experience. They might have seen someone having breathlessness in the past and dying. So these memories and thinking will cause anxiety, panic, again causing breathlessness. And what happens when someone is breathless? They cannot move. The activity reduces. They tend to be on bed or on chair. They isolate themselves and they need more help from others. So they use less of their muscles. When they use less muscles, what happens? There is deconditioning of all the muscles of respiration. That will increase the breathlessness. So when you don't, it's like any other skeletal muscle. When you don't use the muscle, when someone is a paraplegic, who is not walking for a period of months or years, what happens? They will have muscle wasting. Their legs will become very thin and they cannot walk. Same way, if they don't use the respiratory muscles efficiently or if they don't do exercise, their muscles become deconditioned. So there will be more and more breathlessness. So this is called as chronic breathlessness syndrome. So all these act as a cycle. So when you treat breathlessness, we have to treat the physical causes. We have to treat the thinking pattern, that is reduce anxiety. And the third part is improve the functioning, give exercise or improve the muscle functioning. So these are the three elements of treating breathlessness. Sorry. So what are the causes of breathlessness? As we said, there are cancers associated, breathlessness associated with cancer, like it can be primary cancer or a metastatic cancer to lungs. There can be lymphatic infiltration by the tumor. So when there is lymphatic circulation affected by the tumor, there can be breathlessness. Pleural effusion, you might have heard about pleural effusion in malignancy. Pleural effusion can cause breathlessness. Or sometimes if the tumor is somewhere in the throat, where there can be tracheobronchial obstruction by the tumor mass. And some of the treatment like surgery, when there is radiation structure or some chemotherapeutic agents. So post-surgery strictures, everything can cause breathlessness. So these are the primary causes. And there can be breathlessness in cardiac and pulmonary, late stage, end stage cardiac and pulmonary issues. For example, in cardiac failure, people come, especially in the late stages, you might have seen people being given diuretics to reduce the fluid overload. The cardiac failure patients will have breathlessness. Breathlessness is also seen in angina, arrhythmia, and myocardial infarction. It is also seen in infection. We all know COVID infection, there was breathlessness. COPD, pneumothorax, pleural effusion, and pulmonary embolism. So these are the causes that is not related to cancer, or this can be because of the comorbid illnesses. And pain, as I mentioned, when someone is having severe pain, a few months back, we had a patient with severe pain who was undergoing intravenous opioid titration. Suddenly, they found that the breath rate has come down a lot, but patient was still in severe pain. When we checked the respiration, it was very, very less, like 7 per minute. So we thought the patient is going into respiratory depression, but the patient was in severe pain, not drowsy, not delirious. So we thought, why this patient's breathlessness, respiratory rate has come down. So when I sat with the lady, the thing is that she had a tumor below the diaphragm. So whenever she's breathing, the diaphragm is touching the tumor and it is causing pain. So what she did is, like, in order not to cause no pain, she's holding her breath so that the diaphragm is not moving. So she's trying to take a very less breath. So pain itself can cause breathlessness. And I mentioned anxiety. Even when without any illness, even you are anxious when you are going in for some important exams or any interviews, we feel breathless. Whenever we are anxious, we feel breathlessness. Anemia, very commonly seen in many end-stage diseases. Anemia is very common. So this is to understand that the moments you see breathlessness, it is very important to check whether the patient is anemic, check whether the patient is anxious, check whether the breathlessness is due to pain, check whether there is any other metabolic disturbances. And how do we assess breathlessness? History and physical examination, we all know, but we have to keep in our mind that it is multifactorial. As I mentioned, breathing, thinking, and functioning. So we have to ask about how do you breathe? Is there any pain associated with breathing? Are you anxious? What is that you are thinking when you have breathlessness? So all these questions are very important in assessing breathlessness. So again, similar to pain, dyspnea also has multiple dimensions. A good history should include quality. We have heard about OPQRST, right? Onset, when did it start? What is the quality? What is its profile? Whether it is continuous or it is episodic, like only on exertion. How intense it is out of 0 to 10, how intense it is. When it is increasing, is it when you try to sleep, or is it when you try to think about something? And how has it affected your life? Like we say ADLs, how has it affected your ADL? So what is the impact of dyspnea on your life? And what is the concern that you have? You might have heard, like, when someone is breathless and unable to sleep, the caregivers cannot also sleep, right? The loved one is having a lot of breathlessness, and the caregivers will also be sitting through whole night with the patient, and many of them cannot lie down because of severe breathlessness. So these are the scales used in assessing breathlessness. It is called Modified Medical Research Council. You might have heard about. It's a very commonly used and very simple tool for assessing or scoring breath. If you are confused with this, you can just ask 0 to 10. But this is the standard scale used for dyspnea assessment. It is called MMRC. 0 means there is no breathlessness, only on exercise, like when you do running, skipping, or cycling, then you have breathlessness. So it is okay. It is 0. When you are walking, when you hurry or climbing stairs, you have breathlessness. That means 1. And 2 means either I cannot walk as like my colleagues, or I have to stop and take breath even when I walk slowly, is score 2. And score 3 is I have, even with 100 meters or a few minutes on a level ground, I have to stop. and 4 is severe breathlessness. The commonly used scale is MMRC, but this is another scale. It is modified Borg scale. This is another, like if patient cannot express, then you can show these pictures. Then you can score accordingly. You can just refer these scales, but the most commonly used one is MMRC. So what are the physical signs of respiration? You have to check whether how the patient is positioned. Usually they will have the tripod position. They'll be having a table in front of them or a chair. Usually they will be sitting all the time near a table with their hands like this. So it's a, and keeping their head like this, so that it's called tripoding, that position, so that they get more air. And check whether their respiratory muscles are active and whether there is any nasal flaring. Check the respiratory rate and gently do percussion, because we need to know whether there is any effusion, and auscultate. I know you are a group of nurses, but it is very important even for the nurses to auscultate the chest, to understand what you hear. I'm sure you have learned all that in your nursing education, Krebs, Ronchi, V's, everything, but it is very important to auscultate whenever you get a chance. Anyway, you're going there to take the vitals, everything. Just make it a practice that you just listen to the chest and understand what is normal and what is abnormal. And investigations like X-ray or scan only if it is going to help with the treatment. So, what are the the quality or the description of breathlessness? What are the things that we need to document when you assess breathlessness? Severity, either you can ask the MMRC scale, or you can ask the out of 0 to 10, how breathless you are. Ask for what are the precipitating factors, whether it is walking, crying, laughing, or smell of smoke, or when they are anxious, and ask for the trajectory of dyspnea, how it is increasing and when it is decreasing. Ask for past medical history, whether there was any history of asthma, COPD, any heart issue, renal issue, etc. Ask for occupational exposure, because it is not that uncommon. In our country, it is very uncommon, but when people get reference from outside, it is very important to ask for occupational exposure. Ask for history like beta blockers. We know that beta blockers can cause breathlessness. And ask whether there is a cough, hemoptysis, wheeze, pain, all the associated symptoms. And do the physical examination and blood test to rule out anemia or any infection. So what is the management steps? First thing, understand, consider the wishes of the patient, and understand the inconvenience and risks of investigations. When you ask for an MRI or CT, it is going to, like, patient with breathlessness, they cannot even move. They'll be simply sitting, they cannot even eat. So when you just say an X-ray or any investigation, it is so uncomfortable or inconvenient for the patient to reach a place and do all these investigations too. So it's very important to think, why am I asking for all this? Am I going to give some treatment after seeing all this? And very importantly, understand the life expectancy. Is the patient dying? Is the patient very terminally ill? Then focus only on symptom management and discuss with the patient and family before we take any decision. So this we have heard, might have heard in some of the session, which is the principles of symptom management, evaluation, explanation, management, monitoring, and attention to detail. This is applicable to any symptom. So these are the experience people have shared. This was a study done by Hull York Medical School in UK, where they asked people to express their feeling when they are breathless. So you can see face inside the cloud, right? They feel that they are good, really good, but their whole head or face is embedded inside a cloud. So there are a lot of pictures in the website if anyone is interested, how patients have, and there is another picture where they are surrounded by nice red roses. So red roses are beautiful, but they are completely covered in red roses so that they can't breathe. So everything looks okay, but they can't breathe. And And a very important point, patient reporting and doctor recognition or nurse recognition. That is, suppose a patient, when I see a patient, I feel that this patient is breathless. But when I ask the patient says, I don't have any problem. So there is a lot of gap between what we think and what we see. Sometimes we see the patients absolutely normal, looks very normal, no breathlessness, but they keep on telling you, I'm very, very breathless. So this was a study, and they found that out of 33 patients who had dyspnea, okay, 33 patients who had breathlessness, but doctor could not recognize the in 9 of them, doctors could not recognize the dyspnea. So we think that they are okay, but they may not be. Uh, Maybe because it is multi-dimensional, because it is not just showing this, but it is associated with many, many other issues also. So there is a gap in what we see and what they are going through. So it's very important to ask them. Correcting the correctable. If there is an infection, treat the infection. And understand that COPD, only a small percent of patients will get benefit from bronchodilators. And if there is a effusion, a pleural or a pericardial effusion, treat the treatable, drain the effusion, and then the patients will feel better. When there is a congestive cardiac failure, then it is important to reduce the fluid overload. So these are the correctable measures that we should think of first. Then some of the times we need to ask for radiology or oncology consult for correcting the correctable. If suppose there is a huge tumor compressing on the trachea or tracheobronchial tree, then it is very important to give some radiation and to shrink the tumor so that the patient can breathe better. Or if there is a huge mediastinal mass, it is very important to send them for radiotherapy referral. Or if the tumor can be resected, then it is important to refer them for surgical techniques, or draining the pleural or pericardial effusion. So these are the correcting the correctable. Very important point in breathlessness. It is not just the medication that helps. Non-pharmacological management of breathlessness plays a very, very important role. So these are some of the proven evidence-based techniques. Walking aid. So I have seen in other countries when I went to visit hospices that people with breathlessness, they use the walker or a tripod or some assistance. So it is not because that they are weak. If you use a walker or a tripod while walking, the effort is less for the body. So more energy can be utilized for breathing. You don't need to spend energy for walking. Rather, that energy can be utilized for breathing. So assistive devices or walking aid is very, very important. We don't really think about it. So suppose a breathless patient going to toilet, if their caregiver is supporting them, or if they are using walker, the breathlessness will be less. So these are the important nursing part that you should encourage patients to use support, or even sitting. When the patient is sitting and eating or sitting and talking, it is very important to sit with support, because when you sit without support, they need a lot of energy to sit without support. If you give us support, then some of the energy can be utilized for respiration, to breathe properly. So it is very important to make this small correction so that they can breathe at peace. You can teach the caregiver chest physio and personally breathing, how to breathe, how to do the inhale, exhale, respiration, how to improve the lung capacity exercises, all can be taught. And other one is fan. Fan is not the ceiling fan, but the small handheld fan is very, very useful in terms of non-pharmacological management of breathlessness. It can be shown to the side of the face. So it seems that it stimulates some of the nerve endings, because we know that the side of the face is very well innervated by the facial nerve. So when you blow a small handheld fan against the side of the cheek, that has shown a great improvement in breathlessness. So that is one very important non-pharmacological method. And very importantly, with using the support, the posture, the walking, not go fast to the toilet, but to take small steps and small arrangements like using a wheelchair, and keep the patient's bed near a window where they can get some fresh air, not in a corner where you don't have any doors or windows. So these are the non-pharmacological management for breathlessness. Pharmacological, there are three levels that I'll come to it in detail. So first is oxygen. When the moment we hear breathlessness, the first thing that comes to every medical professional's mind is oxygen. Or any caregiver. The caregiver thinks that my loved one is dying without oxygen. So in terminal illness, there is no correlation. In COVID, I understand hypoxia, they need oxygen. But in terminal illness, there is no correlation with dyspnea and hypoxia. There is no hypoxia that you need to treat with oxygen. For patients with life-limiting illness, the effectiveness of oxygen for breathlessness is similar to air. It is even when they breathe normally and you give oxygen, the effect is very, very similar. It is a huge comparative study done where a group of patients were given oxygen, a group of patients were given room air for 6 days for 239 patients. And they didn't know what they were getting. Both were given some prongs. One was getting oxygen, one was getting room air, and there was no significant benefit seen with oxygen therapy. So in end stage life-limiting illness, in terminal illness, oxygen doesn't have much role. If you think that oxygen might help, then it is advised to give an oxygen trial. Give oxygen for first 10 minutes and see whether the patient is getting some benefit. Ask the patient, not the caregiver or the oximeter, ask the patient whether they are getting some benefit out of it. If the patient is telling that I am feeling good with oxygen, then you can continue. But otherwise, there is no indication to continue oxygen. So the next line of treatment is opioids. Opioids have very strong evidence in treatment of breathlessness. You might have heard about opioids in pain. And when opioids, we don't use the same dose as we use in pain. The carefully titrated dose can be used for treating dyspnea. I'll come into it later. So it is the mainstay of drug therapy for breathlessness in life-limiting illness or in terminal illness. There is a strong evidence that even the ABG, the parameters will normal. If you check saturation, if you check the ABG, it will show problem. The saturation will be low, but the patients feel that they have good relief. And it is mainly because of its central action. It reduces the perception of breathlessness. Patients feel very, very comfortable. They don't feel breathless. And ultimately, that is what we are aiming at. We are not aiming to take the saturation to 100 when someone is dying. When someone is dying, saturation has to drop. No one can die with 100% oxygen, right? Saturation will come down, but the patient will feel very, very comfortable. Oxygen is just like any other intervention or a drug. Not all dyspneic patients benefit. I think after COVID, only we are starting this much discussion with oxygen. And it is very important to understand, if we have to give oxygen, better to use a nasal prong than an oxygen mask, because when someone is dying and at the later stage of life, when you keep a mask, it is a barrier to communication. They can't express themselves and it is very scary. I don't know how many of you have tried on oxygen mask. I have tried. You feel like you are actually going to die, like in movies where you are given a mask and then you feel that I literally felt that I'm dying. The moment it was removed, I felt quite comfortable. So it's really scary for many patients when you put in that, and it is a very big barrier for communication. They may want to say something and they may not be able to remove it on their own because they are tired. So that's very and in our setting, last 10 years, I hope Sister Shiva has more than years of experience than mine. where patients, we ask patients whether they want oxygen, they keep removing it. I don't want. It is the family who insist on oxygen. So we talk to the family that what is it important that is important to you? Is it the comfort of the patient? Then let us ask the patient whether they are comfortable. And very often they say that I don't want this. Please take it off, and they keep removing it. And how do morphine act? It reduces the perception of dyspnea. So what is perception means? Patient's understanding. So patient is not feeling dyspneic because they don't feel much uncomfortable with dyspnea. That is the main action of morphine. And sometimes it says that it has some centrally anti-anxiety effect also. So we know that when there is hypercapnia, there is increased breathing. If you remember your old lessons, whenever there is hypercapnia or hypoxia, we tend to breathe more. So morphine, what morphine uses is that whenever there is hypercapnia, reduces the ventilatory response. It will train the brain that don't breathe more. We know that hypercapnia is there, you don't need to breathe more. So that's one simplified way I can tell it. And there is a lot of evidence on use of opioids. These are the evidence, and I'm not reading all these things. When we start morphine for breathlessness, it is very important to start a very low dose. That is, here it is written sustained release morphine because it is a very Western study. But in our setting, what we use is a very small dose, even 2.5 or 5 milligram of morphine 6th hourly. You don't need 5 mg 4th hourly or anything. You just need 2.5 to 5 milligram every 6th hourly or 8th hourly. Recent studies have shown that you just need 1 milligram of morphine to start with. That will reduce the dyspnea. If the patient is already on morphine, you can increase it by 25%. And if it is episodic breathlessness, that is exertional breathlessness. So suppose your patient is telling that when I go to take bath, when I go to toilet, after bath, I feel so breathless. So I am unable to take a bath. So we tell them, you take morphine after half an hour or 40 minutes, then you go and take bath. Because that is the time, like same way we tell in pain also. That is the time when they have most symptom control. So that is the time you can go and do your activity. So time the morphine according to their episodic nature of breathlessness. And the moment you prescribe breathlessness, morphine, they will ask you, morphine is a painkiller. Why do you give morphine? You will be asked, the doctors will ask, the nurses will ask, the relatives will ask, everyone around they will ask. But you have to say confidently that morphine is proven to be very effective. It is evidence-based. That's old school of thought, but now morphine is very widely used for treating breathlessness. So another drug which can be used is corticosteroids, that is dexamethasone in higher doses. The third drug, so these are three important drugs which is used in the treatment of breathlessness. One is opioid, second one is steroids, and the third is benzodiazepines. Benzodiazepines will reduce the anxiety. So whenever they have a panic attack, we can give either subcutaneous midazolam for breakthrough dyspnea. So this is a simple flow chart which is suggested in patients with breathlessness. It has, you can notice it, everything starts with non-pharmacological intervention, and non-pharmacological management should be continued till the end of life care. Handheld fan, relaxation techniques, walking aids, pulmonary exercises, everything can be prescribed from the beginning till the end. And later on, you can consider medication. So to takeaway points will be breathlessness is common in cancer as well as in non-cancer. History and clinical examination is very important, and we should understand and direct our treatment to reducing or eliminating the underlying issues. And very, very importantly, non-pharmacological management are very useful and to be done at the earliest stages of progressive disease. I'll touch a little bit upon other respiratory symptoms also, like cough and hemoptysis. Cough is also very commonly seen respiratory symptom, mostly in cancer and in COPD. And many a times people cannot sleep it can lead to pain because they cough a lot. Urinary incontinence. Every time when they cough, they'll have leaking of urine. They get tired and they may not be able to sleep. So cough is a very, very common symptom and a very distressing symptom in palliative care. It can cause a lot of complication, like it can have pain, fracture of ribs in severe cough, incontinence of urine, exhaustion, and disturbance in sleep. And it has, I'm not going into the detail, it has 3 phases. All this we might have learned long time back in physiology. That is not needed. But you need to understand that cough is mediated through the C fibers. Where have we heard the C fibers before? We have heard that in pain. A delta and C fibers are involved in the pain pathway. So what are the causes of cough in palliative care? Tumors, which can compress the airways or the lungs, involvement of pleura or pericardium or the blood vessels can also cause, the irritants may be circulating through the blood vessels, or very commonly in palliative care, aspiration. When someone tries to feed terminally ill patients, they will aspirate the contents. Or head and neck cancer patients, for example, will have so much of secretions, mucus secretions, hyper secretion of mucus. They'll also be having cough. How do you assess? Assessment is the same: history, physical examination, and if needed, chest radiographs. And what are the treatment? If it is a tumor compressing the respiratory system, then we need to refer for radiation therapy. Or if surgery is feasible, then surgery. If it is related to, if it is cannot do any radiation or surgery, then steroids can be given so that the compression is relieved. And if it is due to infection related to aspiration, then we need to give antibiotics. Antitussives, we know that we all go to the medical store and get a cough syrup, but there are different types of antitussives. We need to understand what type of cough we have, and accordingly we have to choose antitussive. There is actually centrally acting and peripherally active antitussives. The centrally acting ones are the codeine, the ones which has codeine, or dextromethorphan. Dextromethorphan, I must say, I think Alex lozenges and Alex cough syrups. It has dextromethorphan. It is a centrally acting antitussive agent. And there are some protussives. That is, some patients you might have seen, they can't cough. They say, I have sputum here, but I cannot cough it out. So then we have to give something which can make the cough more effective. That is ambroxol or bromhexine. And there are some soothing substances like glycerol. So it is important to choose the right antitussive than just prescribing. But I think in market, we get a combination of everything. So it's very important to understand what is the purpose, what kind of cough this patient has. Another important symptom for today, everyone, I want everyone to learn about this, is noisy secretions in the last hours or days of life. It is called death rattle. It is due to the vibration of the secretions. When patient is unconscious or semi-conscious, they are too weak to spit it out or cough it out, so that there will be pooling of secretions, and when air passes through it, it makes a noise. This is called death rattle. Death rattle is very common, very, very common. I think most dying patients, old age related dying, any type of dying, it is very commonly seen. And when the death rattle appears, we know that the patient is going to die in another few hours. That's a very strong predictor of death. So what can be done? Again, on pharmacological method, position the patient to one side, giving chest physio, and to explain to the caregivers that it is not breathlessness. It is because the patient is unable to swallow or spit it out, and the secretions is being pulled just at the back of the throat. So you just need to change the position to one side so that they can breathe normally. One medication that can be used will be glycopyrrolate sublingual. Any drying agents can be used. The last symptom, I guess, will be hemoptysis, that is coughing of blood. when someone is, we have seen a lot of very distressing hemoptysis when someone is dying, and when it is if they are expectorating more than 300 ml of blood in a single episode, that means massive hemoptysis. That means the patient is actually nearing the end of life. It is very important to tell the family that he might be dying soon. I'm not going into the causes because it can usually it is associated with cancer. And when they come with massive hemoptysis, there is not much that we can do. It is very life threatening. We may have to sedate the patient because they have bouts of blood coming out. You can try intravenous or ethamsulate tranexamic acid. That's the normal medical approach. But it is very important if suppose someone is having a tumor which is about to rupture, we know it from the CT scan, it is very important to keep the emergency box, which will have dark towels, and to make sure that the family understands that hemoptysis can be life-threatening. So I think that is the end of the respiratory symptoms. I have just touched upon hemoptysis because that may not be that common, but in our setting, we do have a lot of experience in people dying out of hemoptysis. The most common symptoms that you might be seeing will be the death rattle and cough. Thank you. I'm happy to take any questions.
Thank you, ma'am, for the excellent presentation. Anybody would like to ask any questions? Please ask. Madam, one question. What about Strider?
In our palliative care setting, Strider comes as an emergency, right? In the end stage cancers where there is compression of trachea. So whatever Strider patients that has come to palliative care, they are usually they might have there will be only one option, that is tracheostomy. So very important thing is to anticipate. Suppose you know that this patient has a huge tumor which might be compressing this. We tell them beforehand there are chances that you might end up in severe compression, that you won't be able to breathe without putting in a tube on your throat. If that situation comes, what are you going to do? Either you put in the tube. If you don't want to put in the tracheostomy tube, we make sure that you are comfortable in our setting. So we don't do any tracheostomy in our setting. Instead, we treat them with steroids. We give steroids so that some kind of edema can be reduced, and there can be little bit of I have seen patients coming with Strider. We thought that they are just dying, but they have lived for another few days with steroids, morphine, and benzodiazepines to reduce their anxiety. So that's the way that we approach Strider in palliative care setting. We ask them, the another option will be putting in a emergency tracheostomy tube, but sometimes that won't be even an option because the cancer will be advanced. But if the patient wants that, we refer them to a medical college. But usually patients say, I don't want to put in the tube because I know that the disease is advanced. And what happens when putting a tracheostomy tube also? The patient cannot go home at all, or the patient's bystanders should buy all these suctioning equipment, and they should be empowered to take care of this tracheostomy at home. And in most cases, that is not going to happen. The patient will end up in having having to be admitted in a hospital where he will have recurrent infections. And it is very, very distressing, especially in advanced cancer. We generally don't, we have the conversation much earlier that this is a possibility when the tumor progresses. What kind of treatment do you want? So that's very important to have the communication earlier. But if you did not get a chance at all to communicate, it just came like a Strider, then we manage with steroids and opioids. Thank you, sister. Any other questions?
Anybody?
Has anyone seen all these symptoms? Have you seen patients sitting unable to lie down because of breathlessness? Have you seen patients with noisy breathing when they are terminally ill? Has any one of you seen this? At least your relatives, your grandparents, when they die at home, have you seen these symptoms? Anyone?
Hello, ma'am.
Yes, sister, tell me.
Uh, actually, I am not clinically actually involved with the patients. I'm more of in the administration. But as far as I have seen, most of the cancer patients, like on their late stage, most of them used to have breathlessness. I think, yeah, and then like they used to be very anxious and things like that. But then hemoptysis, not very often.
Thank you for sharing. And that might be very distressing for the patient and the family, right? They might be all be
Definitely,
anxious.
ma'am. Yes, ma'am. Yes, ma'am. Yeah, recently, just 2 days back, we lost one patient like that. CA esophagus. So I think they were given him opiate and this, what do you call, sedated with midazolam.
And was the death, was he comfortable after giving all these medications?
For some time,
Yeah.
like especially on the last day, he was struggling a little bit, but then for early, like codeine was going on and also midazolam was there. For some time he rests on the daytime, but then like he passed away on the evening.
Thank you. Thank you for sharing that. Someone has raised a hand.
Sunny, you want to say something?
Hello. No, ma'am. Oh, actually, ma'am has told about any relatives or any patient you might have seen seeing breathlessness. So I have just said then I have an experience of witnessing a patient who is at the end of the care and he was facing a severe difficulty, breathlessness.
So I hope I know that unless your doctor is telling you to give opioids, you can't give opioids. But at least the non-pharmacological treatment or talking to the family, uh, um, all those areas that you might be able to do for as a nurse, right? Yeah, I think that was to everyone. So non-pharmacological methods is very important in the initial stages. So, and it's very important to have good communication with the family as well as the patient, because your loved one is breathless, everyone will panic. So it's very important to have sit down and talk to them, make them understand what is happening, and yeah, tell your doctors that opioids might help, and please undergo training how to use opioids if they are still unaware of it. So these are the steps that can be done. And especially when someone is dying, the nursing part plays a major role in controlling the death rattle, because again that is a very distressing symptom that doesn't need any medication at all. Very rarely we need to give medication for death rattle. It's always the sideline position, convincing the family that why it is happening, where it is coming from, generally give the chest physio. So all these are the non-pharmacological methods. So and then you see it's very common when someone is dying, the noisy secretions are very commonly seen. Anyone else have any questions?
So I think no, ma'am, no questions. So unfortunately, we don't have a case presentation today. So for kind of the sessions, Madam has covered all the aspects of the care, especially how to manage breathlessness patients and cough patients and hemoptysis patients. And always I would like to highlight few things about the management of nursing management of those patients. The first and most important thing is always try to develop a therapeutic relationship with the patients and the family. That is one of the most important thing. So as Madam mentioned during the presentations, anxiety can worsen the breathlessness. So this is one of the main problems. What we do is, as nurses, I know you are busy in your settings, but if you get time, go with the patients and be with the try to there and be with the patients and listen their anxiety and try to reduce their anxiety and convey some words like we are here and we are with you always. If they have any problem, that way we are there for support them. So that way we can able to improve the confidence level and reduce the anxiety level of the patients. And the second thing is, Madam, during the presentation, Madam was mentioned about the oxygen therapy. So if you are using oxygen therapy, after 10 minutes, you check with the patients the oxygen. You have to check whether the oxygen can help the patients or worsening the dyspnea. So that is very, very important. Always you can use nasal prongs. That is also important. So that way we can reduce the communication barrier also. Okay. So these are the things I want to share with you all. And before leaving today's sessions, I want to talk to you a few things about our sessions. Madam, once again, thank you. And if you want to leave, you can leave.
Yeah, thank you everyone for patient listening. Thank you.